Today we'd like to welcome back Dr. Robert Montgomery. He was here several years ago sharing, I believe was probably the earlier experiences with his program and their protocols on desensitization. I will defer to this white sheet with his disclosures and a longer biography. We could probably spend a half an hour talking about Dr. Montgomery's biography, but as you can see, he is Chief in Division of Transplantation, Director of the Incompatible Kidney Transplant Program at Johns Hopkins, and Director of the Comprehensive Transplant Center. And today he's going to talk to us about overcoming obstacles in sensitized kidney recipients. And again, we'd like to welcome back Dr. Montgomery to University Transplant Grand Rounds.
Thank you so much. Is my mic on?
It's on.
You can bring the lights down, I guess, or don't bring them down too far.
Don't do it all.
So I guess, I can't remember how long ago. Can everybody hear okay? Is it too loud or about right? I was here quite a few years ago, I think, and we've been at this now for almost 15 years. So I'm going to kind of focus on the lessons that we've learned over the years. We'll see how that works. So these are my disclosures, some small grants from pharma, some honorarium, Spire Learning that sponsored this today. They don't have any control over content. These are all my own slides. And then I'll be mentioning a few off-label uses of a couple of drugs. So for patients who are highly sensitized, the algorithm or decision tree really depends upon whether or not they have a live donor. So if they don't have a live donor, right now there's a fairly limited number of options for the patients. There's high-dose IVIG, which people seem to have variable success with. I think that the bottom line for high-dose IVIG is if the antibody is a very low-level antibody, not very strong, it seems to work, but if it's a strong antibody, it doesn't. And rituximab, I'm not going to go into much detail on rituximab, but I think that there's a mixed bag. It may prevent, we have some data that suggests that it may prevent rebound of antibody after the transplant, but it doesn't lower antibody on its own. So what I'm really going to be focusing on are the patients who have live donors and the options that they have. And basically there are three options. They can undergo desensitization, and I'll be talking mainly about plasmapheresis and low-dose IVIG. They can undergo paired donation or a hybrid technique that we started talking about quite a few years ago, where you use your kidney paired donation pool to find the best donor for the patient. But for these highly sensitized patients, you're never going to find a compatible donor. So you still have to do some desensitization. I'll talk a little more about that. So lesson number one, we've got a number of new fancy drugs that people are talking about and some people are using, but plasmapheresis and low-dose IVIG, we've kind of stuck with that protocol for many years, so now I think we can say some meaningful things about it. And even though this machine is, it looks like Lost in Space robot and everything, it has no sex appeal, it actually works very well. And it can lower donor-specific antibody in a fairly predictable way. So this is the protocol that we've been talking about, that we first published in 2000. And essentially it just involves every other day plasmapheresis. We guesstimate how many treatments the patient's going to need based on the strength of their antibody when they begin pheresis. We start their immunosuppression. We do some induction therapy. We continue their plasmapheresis after the transplant. The low-dose IVIG, we're sort of learning more and more about what that does. That was sort of an empiric therapy before, but I think the main effect of that is not the immunomodulation, but the suppression of production of endogenous antibody. So we think it prevents rebound of donor-specific antibody in between treatments. okay, because there's an endogenous mechanism that senses the amount of antibody in the system and then will, cause more to be produced. So our goals, we certainly don't take patients to the operating room with a positive cytotoxic cross-match, but you'll see later that now most of our patients are starting out with a negative cytotoxic cross-match. But I think what's important is the goal of this plasmapheresis after the transplant is to try to get them down to a level that is consistent with a negative flow cross-match. And how successful are we? Well, these are results of different flavors of antibody, class 1, class 2, the DR antibodies. Several months after we've completed desensitization. So what this tells you is that if you have a class 1 antibody, there's a high likelihood that that will be completely eliminated, undetectable, after you do your desensitization. But that's not true of class 2. In fact, the DRs, it's more likely that you'll have persistent antibody than not. So I thought I'd just go over, review the results of our patients who were desensitized. So all these patients had donor-specific antibody and underwent at least 2 treatments of plasmapheresis. And now we're up to 323, and this extends over a period of 15 years. And you can see that we've been doing a lot of this sort of hybrid technique where we combine plasmapheresis and desensitization. I'll mention that a bit later. So, 44 of the patients actually were ABO incompatible, who also had HLA antibodies, so they had a double barrier. And about 25% of the patients were involved in kidney pair donation. These are very sensitized patients. This is a cytotoxic CPRA. The average is 86. This is the distribution of cytotoxic CPRAs, and you can see that about 60% of our patients have a CPRA above 97%. Those are the patients who are really difficult to get transplanted through any technique, and particularly kidney pair donation. I'll talk about that. There's a lot of retransplants. This is the number of allografts, and about 15% of our patients are receiving their 3rd or 4th kidney transplant. And I think very importantly in terms of some of the data that I'll show later on outcomes, these patients have been on dialysis for a long period of time or have had previous transplants, had many years of renal replacement. And this is sort of the distribution of years of renal replacement, and you can see about half the patients have had more than 10 years of renal replacement, so lots of time to accumulate comorbidity. The number of treatments, the average number of treatments, the median number that are necessary before the transplant is 3, after the transplant is 4. And I think one really important thing to note is that when the patient starts on plasmapheresis, there's a very high probability that they'll get a transplant, okay, and there are the numbers there. And you can see the effect is pretty durable in terms of mean creatinine over the years and in terms of the current creatinine. So these kidneys aren't crippled and sort of limping along. In terms of the strength of the antibody, which seems to be extremely important that we start with before we do desensitization, you can see about half the patients have a negative cytotoxic cross-match but a positive flow. And about 25% of the patients have a positive cytotoxic cross-match. And then this group of patients that has a negative flow but clearly has donor-specific antibody by Luminex testing. The rejection rate, the antibody-mediated rejection rate for our cohort is actually lower than what's reported from in the literature. It's about 25%. There's a very high rate of cellular rejection. Again, regrafts, patients who are very immunologically challenged, that's probably why there's a fairly high rate. So these are the outcomes. This is death-censored graft survival. So at 6 years, it's about 76%. At 2 years, it's 92%. This is for the whole cohort. So, you know, the first lesson was that this protocol works and it gets very difficult patients transplanted. And the second lesson, which is very much linked to that, is that, you know, because if you looked at this, you'd say, well, wait a minute, you know, our live donor transplants do better than that, right? And they do. But you have to compare apples and apples. You have to compare the options that are actually available to your patient, okay? If you have a patient who has a PRA of 100%, getting a compatible transplant is not an option. So that shouldn't be your comparison group to determine the effectiveness of your therapy. And we looked at this a few years ago where we took our, then I think it was 211 patients that we had desensitized, and we matched each one of those patients to 5 patients who were waiting on the UNOS list for a compatible organ. And we watched to see what happened to our patients, and we watched to see what happened to their matched controls. And these are the various features that we matched. Blood type, gender, PRA, number of previous transplants, years of renal replacement, those kinds of things. So this is the kind of money shot, the critically important slide, I think, for comparing apples to apples. And what this shows is our patients right here, okay? So at 8 years after the transplant, there's about an 80% chance that they'll still be alive. This line here, this is sort of the intent to treat group. So these are patients who stayed on the waiting list until they got a compatible transplant. And you can see at the end of 8 years, only about 50% of them were still alive. So then we looked at these patients and determined that only 16% of those patients that were in the matched control group that we followed actually got a transplant over 8 years. So it's pretty extraordinary, actually. So then we said, well, look, for 84% of our patients, the option isn't between waiting for a compatible transplant and getting one. It's being on dialysis versus desensitization. And that's what this line right here shows you. And that 16% transplant rate brings that line up to there, which is pretty extraordinary. But at the end of 8 years, 30% of the patients are still alive who stayed on dialysis. So very lethal disease in patients such as, in the types of patients that we see who are sensitized. And I tell my fellows, if this were a cancer treatment, people would be lining up outside your door to get it, because it's pretty extraordinary survival benefit. So why do these patients seem to have more trouble? Why aren't they sort of from central casting? Well, I think this study that we did a few years ago shows why. These are all different comorbidities: cardiovascular, peripheral vascular, dysrhythmias, whether they're in a wheelchair, the number of previous transplants. This is the percent of live donors nationally that have that comorbidity, because these are all reportable to UNOS. And then this is the percent of our patients that have it. And then this is the relative risk of death for each of these comorbidities. And you can see that our patients have a lot more comorbidity, and that comorbidity is associated with a higher death rate. So lesson 3, don't bite off more than you can chew, okay? So one thing that's become very clear over the years from clinical practice is that, and I've alluded to this, if you start out with a higher level of antibody, the patients don't do as good, okay? So this is the graft survival. This line right here are patients who started out with a positive cytotoxic cross-match, so a really strong antibody. And these two lines are the flow and the negative flow, but positive DSA, and these are the patients that are being considered in the Kaplan-Meier at each time point. Now, one thing I will say is that despite this, in that New England Journal paper, we still showed a survival benefit for this group of patients, okay? So we want to try to avoid desensitizing a patient that has really strong antibody, and now we have some other options, but they still do better than if they go on the list or stay on the list. One outcome that's been kind of a bit surprising, this is graft survival by the class 1, class 2 of the donor-specific antibody. And then this line, this top line, is patients who had class 1 and class 2. Most groups have shown a pretty significant difference between class 1 and class 2. When I think about class 1, I think about that it's sort of like acute leukemia. You know, you either get cured or you don't, right? And things happen pretty rapidly. Whereas class 2 is sort of like chronic leukemia, you know, where the antibody tends to persist. You can't really get rid of it. Anyway, the results, at least from our study, show that there's not a really big difference. But again, what's out there in the literature is that these class 2 antibodies that persist cause injury and cause transplant glomerulopathy over the long run. And indeed, that is the case, but these are data from the Mayo Clinic, which basically show that the positive cross-match cohort has a higher rate of transplant glomerulopathy at 1 year. And if they have an antibody-mediated rejection early, that rate goes up to about 44%. So there's been a lot of interest in looking at drugs like complement inhibitors that reduce this rate of antibody-mediated rejection early on because of its association with transplant glomerulopathy. So lesson number 4 is you don't need to bite off more than you can chew because now you have other options. So you're probably aware that for many years, desensitization and kidney pair donation seem to be sort of competing strategies. And some programs would be desensitizers and some would be exchangers, and they were always very separate. One of the things I think that made our programs kind of unique is that very early on, we created like a single tent where we kept, you know, all the patients who had antibody problems. And we also had under that tent altruistic donors and patients who were blood type incompatible. And I think that helped us to learn pretty quickly that these aren't competing strategies, but in fact, they can be used very effectively together. So these are the number of kidney pair donations by year in the US. And you can see that in 2011, we did over 500 pair donations. Now, there's a couple of important things that have come out of the work that Dori Segev has done at our institution, which, is that clock working?
No.
Oh, okay.
It's 20 after.
Okay. So anyway, he's sort of a mathematical genius, and his wife is a mathematician from MIT, and they did all these simulations, which really gave us a good sense for who benefits from paired donation and who doesn't, and kind of what is the potential of paired donation nationally. So this work comes from them, and basically they were able to determine that there are about 3,500 patients each year who had a willing live donor who was either blood type or HLA incompatible with them. And there were about 600 or 6,000 patients who are currently on the list who could have had a live donor except they were incompatible. And using fancy matching algorithms that are now very common in the big kidney pair donation pools, you can get about 50% of those patients matched in a single run, okay? But that leaves about 50% that are unmatched. And the reason that they're unmatched is because they're hard to match, okay? So when they get put back into the pool for the next match run, they're still hard to match, okay? And they're dependent on this new influx of new registrants. But what happens to paired donation, and the group across town has learned this lesson, that as time marches on, your pool becomes enriched for really hard to match people. So you get all these transplants early on, and everybody's high-fiving, and this is the greatest thing in the world. But then you quickly realize that there's a problem with some of these patients. And here's the problem. Well, this is one aspect of the problem. Okay, so it's a little bit of a complex slide, but let's say you take a patient who is an AB recipient, so the blood type doesn't matter, right? But they have a CPRA of 80%. If we searched in this room, we could probably find, because the number is about 100, not quite 100 people here, but with 100 people, we could find a match for this patient, okay? So this is the predicted match rate, okay, just based on what we know about genotypes, HLA genotypes. This is the match rate in a kidney paired donation pool for this patient, okay? It's less than 10%. Why is that? The reason is that people are sensitized against common HLA molecules. Common HLA molecules share epitopes with less common HLA molecules. And so all of your highly sensitized patients are looking for the same rare genotype. They're looking for the same donor who has a rare genotype that all their antibodies don't cross-react with. So that's why there's this huge disparity, and that's why kidney paired donation can't be a home run for all the patients. The other reason is blood type skewing. So if you look at, this is NDD is non-directed donors. So this is our normative blood type distribution in the United States, okay? If you look at recipients in a kidney paired donation pool, that's their blood type distribution. So there are lots of O patients and not many A's, right? And the reason is that the most common blood type incompatibility is an A donor and an O recipient. About 30% of your pool are there because of that blood type incompatibility. So you got lots of O's. And your paired donors, it's just the opposite, right? Because if you have a donor who's an O, they're going to give directly to you unless there's an incompatibility, a HLA incompatibility. So again, you've got all these A's because of the A to O problem. And so what this does is it reduces the likelihood of a match because you don't have enough O donors for all these O recipients, okay? Now, one of the, when the paired donation chains first started to be discussed, everybody thought, okay, well, these things can go on forever, right? You get one altruistic donor who starts the whole thing. That's not true, because after a certain number of iterations, you select out donor phenotypes, that mainly blood types, that don't match well. So these stall. They eventually stall. Now you can get a good run out of a lot of them, and if you're willing to cross a blood type, you can keep them going, right? But that's why. So this, I think, is a very important slide, because when I see a donor-recipient pair in clinic, I know something about their phenotype. I know what their blood type is. I know how sensitized they are. I know about their donor's blood type, and I can tell them pretty quickly whether or not they're going to benefit from paired donation, okay? So if you'll bear with me for a second. So these are the donor blood types and recipient blood types. So remember I mentioned earlier that if you have an unsensitized patient and you do a match run and you have a paired donation pool with 100 pairs in it, there's about a 50% chance if you have an O donor that you'll find a match, okay? Now, if your recipient has a PRA of greater than 80%, that drops way down. If you expand the size of the pool, you can get a higher match rate, okay? But it's not, an order of magnitude. It's 14%. So, so that's important. The other thing is if you have a blood type A donor and an O recipient, there's only a 13% chance that they're going to match. Okay, and I'll talk about how that affects our decisions. But if you have a B to an A or an A to a B, it's 70%. Those patients should stay in the paired donation pool. They shouldn't be desensitized. So how do you increase the match rate of highly sensitized patients in a kidney paired donation pool? Well, I showed you an example where if you expand the size of the pool, you can get more matches, right, to like a national level versus a local level. If you increase the number of new registrants, but that's kind of a fixed number over time. If you increase the genetic diversity of the pool, because remember I said everybody wants that rare genotype, that would help. If you increase the number of O donors, that helps a lot. And remember, because that gets rid of the blood type skewing, right? And you could do that by entering compatible pairs. And I think there's been a few groups across the country that have done this. And generally, why would a compatible pair want to enter into a pair donation? Oftentimes, you can get a benefit for the recipient in a compatible pair. I'll give you an example. 2 weeks ago, I had a 19-year-old girl whose grandma, who was like 68, wonderful person, great intentions, wanted to give her kidney to her 19-year-old granddaughter. And so we talked to them about this. They went into the pair donation pool, and she wasn't sensitized or anything, so we found a match pretty quickly, and she got a 25-year-old kidney. And grandma gave her kidney to somebody in their 60s. So that's one thing that has not been explored very thoroughly. You can remove the HLA compatibility requirement, and this is what I talked about earlier with the hybrid technique, or you can remove the ABO compatibility requirement of the paired donation. So the way we do this is we take the HLA antibodies with a strength below whatever threshold we're comfortable with, okay? Because we can, with Luminex single bead testing, we can look at their whole HLA protocol, and we can, in a semi-quantitative way, determine the strength of all their antibodies. So basically, any antibodies that are below whatever we're comfortable with for getting a good result from desensitization, we drop those out, and those are no longer unacceptable antigens for that patient. Does that make sense? And then we make them all AB blood type, so they can see the full range, because we think it's easier to cross a blood group barrier than an HLA barrier, okay? So if you look at our, and this isn't quite updated, but if you look at our patients who were transplanted with this, combined kidney pair donation and desensitization, so again, you search for the best donor for that patient, but they're not completely compatible, either by blood type or HLA, and you have to desensitize them, but only a little bit. And you compare that to patients who get kidney pair donation alone. So these patients have a mean CPRA of 94% and these 0, right? The results are quite good and fairly similar. So this is the line for the patients who had to be desensitized as well. So good outcomes. This is a 6-way pair donation that we did that George Bush invited us to the Oval Office with all our patients. These are all our patients back here who are involved in the swap. Kind of a high point for our program.
Weekend Update with Amy Poehler and Seth Meyers.
Surgeons from Johns Hopkins University Hospital successfully performed the first ever 6-way kidney transplant last Saturday. Disturbingly, all 6 patients had only gone in for flu shots.
So it was kind of fun.
So today, you are not 15 individual doctors. You are one team of surgeons representing this hospital. Is everybody clear on that?
Why would they need so many doctors for one surgery?
Because it's not just one surgery, it's 12 surgeries. 6 kidney transplants in 6 ORs, all at the same time. Paired matching kidney donation. Just 6-way swap. 6 people donate kidneys to total strangers. 6 people get kidneys from total strangers. 12 people walk away happy.
Paired matching kidney donation.
Otherwise known as pseudoabdominal surgery.
I just get a chill when she says that.
They'll be done first, followed by the recipients. Each pair will be color-coded so as not to confuse them. This surgery is a hornet's nest, people. So work quickly but carefully. Use each other. Operate as a team. Let's go make medical issue.
So this was great because my kids started to talk to me after this, you know. So that was the best part of it. They thought it was pretty cool. But so that was quite a few years ago, and you know those early swaps got a lot of attention, which actually, you know, media is a fickle friend, but that helped this field quite a lot. And you know, because there was this question of the legality of paired donation and everything, it sort of brought that whole issue to a head and led to the passage of the Norwood bill, and then everything kind of opened up. So this is the kind of swap that's done today. This is a chain, or what we call a need chain. It unfolds over several days rather than these big swaps, you know, that occur in one day. And you have pauses where you have a donor that's called a bridge donor who waits, you know, for the next recipient to be matched. And the kidneys are flown in commercial airliners from one institution to another. And there are various networks that you can get involved in. We're sort of involved in all of them to try to facilitate transplants for your patients. All right, lesson number 5 is how do you get yourself out of jail? It's always very important. Whenever you enter into any kind of a new thing, you want to know how to get out of jail, right? So one thing that I will say that is good is that we have been getting better at this, okay, over the years. And I'll tell you why I think we've been getting better. But this is our most recent era. Now, the long-term outcomes are almost identical, but what was hurting us were these early graft losses. And they hurt us because, first of all, they're on a personal level, they're tragic. And secondly, from the standpoint of your program, they can put you in jeopardy in terms of CMS flagging. So why did things get better? Well, I think we figured out some ways to salvage some of these early severe AMRs. There is a phenotype, okay? You desensitize the patient, you transplant them about 7 days, 5 to 7 days after the transplant. Their creatinine's, you know, 0.9, everybody's all excited and everything, and then like the next day you come in and there's no urine, okay? They stop making urine. We know from our early experience that if you just start freezing the heck out of them and giving them IVIG and everything, all those kidneys are lost. They develop fairly rapidly cortical necrosis. So the first idea that we came up with was taking them to the operating room immediately and doing a splenectomy. And when we looked in those spleens, they were just packed with plasmablasts, okay? So all the plasmablasts like honed to the spleen early on, and then some of them, well, 80% of them end up dying off, and some of them become long-lived plasma cells and enter into a niche in the bone marrow. But they all go there at first. And if you take the spleen out before the transplant, it doesn't help you, okay? Which we were doing early on. So when we have a patient with this phenotype, and it's very clear, and you know, the antibody goes through the ceiling, you biopsy the kidney, there's C4D everywhere, there's all sorts of congestion, fibrin thrombi and everything. Doing a splenectomy actually gives you quite good early salvage. The thing is that these patients go on to develop transplant glomerulopathy, and those kidneys did not last that long, most of them. At about 2 years, 50% were lost. So then eculizumab came along, And we were very excited about that. And so for a while, we just did eculizumab therapy on our patients. And that didn't work so well either with this phenotype. But when we combined splenectomy and eculizumab, we got really good outcomes. And the reason why I think that works well, that combination, is that the splenectomy drops the DSA level very rapidly. Okay, but there's still antibody in the circulation, so you got to do your plasmapheresis and IVIG to sop that up. But during that time, when there's still a lot of antibody, you're getting tremendous injury in the kidney, and I think the eculizumab can block that injury. And on this next slide, I'll just go to the important part, which is these are the combined patients, eculizumab and splenectomy, and you can see that only 1 out of 5 had transplant glomerulopathy at 1 year, and it was a CG of 1 as compared to these guys who, you know, didn't do very well. So that's what we do now. And this has taken a lot of the fear out of desensitization because we can almost always salvage the kidneys.
Dr. Montgomery, again, when did you institute that therapy? When do you do the splenectomy? And,
You have to do the splenectomy immediately, as soon as you make the diagnosis.
Okay.
So what we require is severe renal dysfunction early on. You only see this like in the first week or so. This is an anamnestic, you know, a recall response that is just really strong. And you can't predict who's going to get this, although the people who start out with higher levels of antibody tend to be more likely to. So bad graft dysfunction without another clear explanation, then they also have to have a huge increase in their DSA. And we can usually get that information back, you know, within 24 hours. Now, we used to take them all to the operating room, we'd open up their transplant incision, we'd biopsy the kidney, do a frozen section, see if we saw fibrin thrombi and a lot of endothelial disruption and everything. Our tissue typing lab is so good now that we don't do that anymore. If they tell us, and they usually call us, you know, the night before and say, oh my God, you know, there's a huge rebound the next day, they're not making urine, and we take them immediately, take their spleen out. Start eculizumab. Works pretty well.
Do you check for donor-specific antibodies in everybody?
Yeah, so around, you know, in our period after the transplant where you mean anyone?
Everybody who gets this protocol gets
Yes.
serial DSA?
They get serial DSAs. And during the early time, they get, you know, a DSA before and after each pheresis treatment. So we can know what's happening with their DSA. Yes?
Was there a group that got sensitive about it?
Yes. We reported that group a number of years ago with the splenectomy cohort. And the ones who got none of the above and just got plasmapheresis and IVIG, 4 out of 4 were lost.
So do you think the eculizumab alone versus nothing is any better?
Probably not, because I think it overwhelms even the complement blockage, you know, possibilities for this drug. So we have done a couple of more recent transplants where we've used eculizumab alone that it seems to have worked better. I don't know why. What we do is we do plasmapheresis because you have to clear this antibody, right? And the Mayo data shows pretty clearly if you don't clear the antibody, because I don't know if you're familiar with their eculizumab data, but they had a really nice paper where they showed that eculizumab drops the likelihood of antibody-mediated rejection in the first 3 months from like 40% to 7%. What they haven't published yet, but they've given some presentations is, so the way they do their protocol is they do desensitization. They start eculizumab on the day of the transplant, and then they don't do any more pheresis. Okay, so some of the patients' antibodies go down and disappear. Some persist, and when they persist, they don't get AMR. So they've showed pretty clearly that antibody levels that would produce an AMR, their patients are just sitting there happy, a biopsy that looks fine. The problem is they stop the eculizumab generally at about 3 months. and the patients still have antibody at a higher rate than we would accept, because we would freeze those patients afterward. You stop the eculizumab, and now those patients are all getting transplant glomerulopathy. It's just late. So anyway, I think this is the thing to do to get out of a tight spot. Okay, so now just, I got, I think, 2 slides left. Just to summarize sort of the thinking behind this and these phenotypes that I've been discussing throughout. So patients, and what I've done is sort of had these sort of catch-all terms and then listed some of the phenotypes underneath each one of them. So patients who are either easy to match or difficult to desensitize, those are the patients who benefit from kidney pair donation, okay? And those patients you should leave in your pair donation pool for a while because they'll likely get matched. Patients who are either difficult to match or easy to desensitize, you should probably desensitize, okay? But unfortunately, there's a large number of patients, and your pool will get enriched with these patients, as I mentioned earlier, who are both difficult to match and difficult to desensitize because they have high levels of HLA antibody to all the common antigens. And those are the patients where I think if you search your pool and find the best immunologic donor for that patient and then desensitize them, you can get most of those patients transplanted. I haven't really talked about ABO incompatible patients, but this is what our algorithm is. If they have if the recipient is non-O, okay, and I showed you the probability of matching in a paired donation for either recipients who are O or recipients who are non-O. So it's very high for the A's and B's and B's and A's, right? But it's quite low. I think it's like 13 or 14% for the O recipients. So what we'll usually do is if they have very high titer antibody and are going to be difficult to desensitize, we'll put them in our paired donation pool, and 15% of them or so will match up and not require any desensitization. But we won't keep them there very long. If they don't match, then we'll desensitize them. But for patients who have low-level antibody, like an A donor, O recipient, we desensitize them immediately. And our results for our ABO incompatibles, we've done 125. These are matched. These are matched with all the live donors in the country. And you can see that basically the results are pretty much the same. So patients who are desensitized for an ABO incompatible transplant do just as well as your patients who have a compatible donor. That's different than the HLA, right? HLA is more challenging than this. So anyway, enjoy the ride while you can. All 3 of these guys died pretty soon after this picture was taken. So, and these are all the people who were involved in our program over the years. And I'd be happy to take a few questions. I think we have a little bit of time. Thank you for your attention. Yes, sir.
You said that when you do splenectomy, pre-transplant it didn't work, post-transplant it helped. Is that just because those plasmablasts just find, like, the spleen, you get them all out, and if it's not there, you can't...
They go other places. I think they go to lymph nodes, and yeah, that's exactly right. It's like a magnet for the plasmablasts. That's how they traffic. Yes?
Hi, you were talking about, so you're doing both types of plasma to CDC and flow on everybody.
Right. So you probably all know about the whole controversy in the tissue typing world about MFIs and the reproducibility of these assays, okay? So our tissue typing group, Andrea Zachary, is very much in the camp that you have to work all these things out in your own lab and that they're not easily then comparable to other labs. And there's a million different reasons why with our current technology. So we have validated within our lab, within our patient population, pretty clearly what level of MFIs with different antibodies, because remember, class 2 antibodies behave differently than class 1 antibodies. what MFI is equivalent to either a positive flow cross-match or a positive cytotoxic cross-match. So not every one of these patients had a cell-based cross-match. And in some patients, we used phenotype panels or single antigen beads to determine what the strength of their antibody was and what it would be equivalent to. And so for many years, we did all the tests. And then we kind of figured out what we needed to do, and we chose the best test. We still do cell-based assays when there's any question, because sometimes the Luminex assay, you know, there are a lot of different artifacts you can get from a Luminex. So if that isn't making sense, we'll go to a cell-based assay. And usually when we finish pheresis or we start pheresis, we do a cell-based assay to just get, we do, you know, both.
So when you're looking at, when you're talking about high antibody, when you're saying they're positive, so it's either positive,
Cyto.
or just a positive Luminex, and you're
Right.
saying it's probably okay to desensitize them because they're, so what kind of MFI are you using, and are you believing in the whole?
Right, okay, so I'm not really allowed to say this, but I'll tell you what the answer to that question is. Generally speaking, depending upon which type of panel you use, but let's say for the phenotype panel, if we consider above 1,000 to be a positive result, but again, it depends on how it actually looks and whether it looks real or not. But anyway, somewhere between 1,000 and 2,000, what most people say. At about 5,000, you're at the flow positive kind of range, and at about 10,000, you're at the positive cyto sort of range, if that helps. Other questions?
At our institution, a little bit in Methodist across the street, you have an old donor that's not related. Pretty much all of those patients should go into some kind of...
Oh, is that right? That's very sophisticated. There aren't a lot of places. Yeah, for sure, that helps. I can tell you from the work that Dory's done that'll bring your match rate from about 50% to about 75% if you're populating your pool with all the compatible pairs where the recipient will have some benefit. Either they get a 6-antigen match, they get a younger donor, they have very strong altruistic feelings, you know, and get some benefit from that. So that can, but you still have that 25%, and everybody who's in that 25% is the same. You know, they're all PRAs above 97%. They have the same phenotype.
How often do you talk a recipient who has multiple donors into having multiple donors donate?
Yeah, that's a great question. So the question is, how, if a lot of, you know, are really motivated patients. People, like a lot of people like them or something, I don't know, but they come with a bunch of donors, right? And so the question is always, do you start working up all those donors? There's some benefit. Well, first of all, we look at the phenotype of the donor. We look at the blood type of the donor, and also some HLA to some extent. And we, you know, if we just, so we'll initially, we'll tissue type all of them and get their blood types. We'll look at them, we sit down, we look at them, and we say, okay, well, this is actually the donor that's most likely to have a reciprocal match, okay? All things being equal, if they're, you know, like a reasonable age and reasonable health that you can get from your questionnaire, we'll advance that person through. Is there a benefit to bringing several patients in? Yeah, there's some theoretical benefit, but remember, you bring two, you know, sort of random patients into a paired donation pool. The likelihood that those two are going to be the best donor for you when you have, you know, 500 other donors, pretty small. So, you know, bringing in a lot, spending the money on working up a lot of donors for one recipient probably doesn't make that much sense. You want to kind of play the odds and bring the 1 or 2 donors through. But we had one recipient who had 75 donors. But you know what was cool about that is that several of them went on to be non-directed donors. So.
Well, is that discussed with them after
Yes.
you find encourage the others?
Yeah, so we say, well, you don't really match that well with, you know, with the person that, you know, you wanted to give to, but if you feel really strongly about, you know, giving this gift, there are a lot of other people who, you know, need help. If they've gone through the whole workup and everything, sometimes they'll do that. Other questions?
I have a question about the chains.
Uh-huh.
Has there ever been, because you use more chains than we do, somebody who reneged on the...
Yes. We've had 3, actually, over the years. What we have learned from the chains, and this is why, you know, we were such strong proponents of the domino. So the domino is all done in one day, okay? Mike Reese, you know, who's with a small program, we would have these discussions all the time at meetings, and he'd say, look, you know, that's fine for you guys because you got all these operating rooms and surgeons and everything. You can, you know, pull off these big dominoes, but for smaller programs, this, you know, is not. So we did a demonstration project on the chain, and now pretty much all of this is being done by chains because pulling off these big dominoes is very difficult. One of the downsides of the chain is that you can have a donor renege. And if you remember how a chain works, it's started by a non-directed donor. And so your recipient will always receive their kidney before you've donated. Okay? And if something like goes badly wrong with your recipient, okay, so that was one. And then the other thing that happens if there's a long period between your recipient receiving their kidney and you donating, and it's usually because you're blood type AB and you're hard to match, then they lose interest. And that's happened twice. You know, their lives change, they, you know, decide to get pregnant, whatever. So now, in the National Kidney Registry kind of figured this out pretty early, and so they insist that all the donors have to give within a week of their recipient receiving a kidney. And we definitely have moved towards that sort of strategy, that you can't have these long pauses.
When you decide that you need to do a splenectomy, have you considered just embolizing this?
We did that in one patient who, so the reason we did eculizumab alone, we started doing that, I read a paper when I was in Seattle, just in a coffee shop from Journal of Immunology, about this mouse study that was done with eculizumab for AMR. And we had a patient who we had taken their spleen out before the transplant, you know, who was a very high-risk patient. It was his 4th kidney and so on. He developed this, and at that time, you know, we had splenectomy and pheresis, and that was it. So we kept freezing him and everything, and you know, he would start making urine, then he'd stop making urine, and the kidney was slowly. So we got an IND from the FDA for compassionate use of the drug, and we talked the company into giving us some drug. And it was pretty remarkable because when we would squirt that drug in, like within a couple of hours, the urine would start. We didn't know anything about the kinetics or anything. And then a couple days later, nothing. So then when we found the splenectomy, that's why, like, we went down that road, and Mayo Clinic, you know, started doing more eculizumab, because we did 2 of these patients early on with eculizumab alone, and one that I mentioned, that kidney was probably too far gone, but didn't recover. But then we did another one, which we reported that did really well, at least initially. And died from something completely different, had a bone marrow transplant. Anyway, so then we started doing the splenectomies, and then we had a couple of patients who came along who weren't good candidates for a splenectomy for various reasons. They had a terrible cardiomyopathy or whatever. And so we started doing eculizumab alone for those patients, and not great outcomes, as I showed you. But we had one 2 years ago who, again, frozen abdomen, terrible candidate for a splenectomy. So we embolized his spleen. Now, we only embolized through the splenic artery, and it was really interesting because we did follow-up scans, liver spleen scans, and the top part of the spleen was still viable. It was being fed by the short gastrics. So it knocked out a lot of the spleen, and his antibody did drop a lot, and we gave him eculizumab. And he was recovering, and then he got septic and ended up in the unit, on pressors for a week, and we lost that kidney. But that's the only time I've tried that. But if you really want to do it effectively, and it's probably important to get the whole spleen, it's going to be hard with embolization. And then you can always get an abscess, too. That's the other thing.
When you did those eculizumab alone patients, what happened to their antibody titers or antibodies?
Yeah, so the eculizumab doesn't seem to affect their antibody titers at all. It just protects the endothelium. Okay, so you still have to freeze them. So I don't know if I mentioned this, but this is the catch. And this is what we've done that's been different than the Mayo Clinic. We've continued to freeze. And based on those 2 early patients, we did work out the kinetics with the company of pheresis. And we know that you have to give 600 milligrams of eculizumab after each pheresis treatment in order to bring it back up to a therapeutic level, okay? A dose of eculizumab is about $18,000. So, to many people that sounds crazy. But if you want to do that, that's what you have to do, because after a couple of pheresis treatments, all your X is going to be gone.
Our problem was just how long to treat. I mean, we did the pheresis after we gave the high dose post. But the question is, how long to keep this whole series going?
Right. So we're looking through keyholes, right? But we have some keyholes. So we watch what happens to their antibody, okay? We biopsy pretty liberally, see what the kidney looks like. We don't, once those things start to come in line, we don't keep treating them. We don't, like when their antibody gets down to a flow level, we don't just keep treating them because we have nothing better to do. And when their biopsy recovers and their antibody is low, we don't keep giving them eculizumab. We stop.
Have you done any bortezomib?
We have. We've treated about 9 patients with bortezomib. We've got a paper actually that is being reviewed right now. It seems to, okay, I don't want to get this backwards. It seems to work pretty well for class 1 antibody, but not class 2 antibody. And it may have something to do with the actual expression of MHC based on how the proteasome affects the assembly of MHC. It's kind of interesting theory. But I have to say I haven't been, and the problem with this field is that people do everything, right? They just throw the kitchen sink. And then to try to find out like what each component is actually doing, if you read all of Steve Woodall's papers, all those patients are getting freeze too. Right, so they're getting plasmapheresis, then they declare that they're pheresis resistant, start them on bortezomib, and then they get better. Who knows why they got better, right? I would say that we've had a few pretty dramatic responses, but not a lot. Sort of like our high-dose IVIG experience. Now there's a second-generation second-generation proteasomal inhibitor that's coming out that's supposed to be a lot more potent. So we'll see what happens with that. But it's still a pretty limited number of tricks in the box. But we've tended to stick with things that we know worked rather than jumping around from one to another. All right. Well, thank you all for your attention.